Welcome to Prism Rounds, where we break down one study at a time. Before we get started, we have to get the housekeeping out of the way. This episode is for educational purposes only and is not medical advice. Okay, today we are tackling a giant. And when I say giant, I don't mean just a big trial. I mean a topic that has probably caused more arguments in break rooms, more heated debates at 3 a.m. over a crash cart, and more firm I'm right, you're wrong stances than almost anything else in critical care.
Oh, absolutely.
We are talking about the RSI trial, ketamine versus etomidate.
It really is the eternal debate of our field.
Yeah.
It's the Coke or Pepsi of the ICU,
Yeah.
the Beatles or the Rolling Stones, ketamine or etomidate. Everyone picks a side, and usually they pick it early in their career and stick to it with, almost religious fervor.
Exactly. And I feel like for the longest time, we've been operating on vibes, I'm a ketamine guy because it feels smoother, or I'm a etomidate girl because it's predictable.
Right. Just gut feeling.
We've been relying on physiology that we thought we understood, or maybe small studies that didn't really give us a definitive answer. But now, that era is over. We actually have the paper in our hands. We are looking at Ketamine or Etomidate for tracheal intubation of critically ill adults, published in the New England Journal of Medicine.
And we're not just skimming the abstract.
No way. We aren't just looking at the abstract. We have the supplementary appendix and the protocol to dig through, so we're going deep.
And the stakes here could not be higher. I think it's important to frame this right at the start. We aren't talking about, elective surgeries in a nice controlled operating room where the patient has been fasting for 8 hours and has a perfectly optimized cardiorespiratory system.
No, this is the crashing patient, the one we all dread.
Precisely. These are patients in the emergency department or the intensive care unit who are critically ill. They are often septic. They are often hypotensive. They are hypoxic. Their physiologic reserve is, it's zero.
It's gone.
And they need an airway immediately. This is the moment where seconds count,
Yeah.
and the drug you choose to push might determine if they survive the next 10 minutes or, the next 10 days.
Right. And for years, the narrative has been this battle between two very different fears. I want to set the stage here because I think every listener has felt this tension. On one side, you have the old dogma surrounding etomidate.
The reliable workhorse, or the old faithful.
Right, the reliable workhorse, etomidate. It's known for being hemodynamically stable. You push it, the patient goes to sleep, the blood pressure usually behaves, it's clean. But then you have this dark cloud hanging over it. The adrenal suppression thing. And honestly, I feel like people throw that term around without really unpacking what it means.
It is the boogeyman of etomidate. And to understand why this trial matters, we have to respect the biology behind those fears. Why were people so terrified of it? It wasn't just a rumor. It was based on, pretty solid pharmacology. Etomidate is an imidazole derivative. And functionally, it acts like a heat-seeking missile for a specific enzyme in the adrenal cortex called 11-beta-hydroxylase.
11-beta-hydroxylase. Okay, I remember seeing that on board exams, but let's be real. At the bedside, I'm not thinking about enzymes. What is it actually doing in a septic patient?
It is the gatekeeper. This enzyme is responsible for the final step in cortisol synthesis. It converts 11-deoxycortisol into cortisol. In a healthy person having, say, knee surgery, you don't really care if your cortisol blips down for a bit.
Right, no big deal.
But imagine a patient in septic shock.
Their body's on fire.
Exactly. Their vasculature is dilating. Their immune system is just screaming. They are desperate for cortisol to maintain vascular tone and to sensitize their receptors to catecholamines. They need that stress hormone to survive the insult.
So the theory and the fear is that you give etomidate to intubate them, you blow up that enzyme, cortisol production flatlines, and suddenly the patient can't maintain their blood pressure hours or days later.
That's it, in a nutshell. The adrenal suppression hypothesis wasn't necessarily about the intubation moment, the first 5 minutes.
Oh, okay.
It was about mortality later. The fear was that by giving this one single dose, you were crippling their immune and stress response for the next 24 to 48 hours, which could lead to higher mortality down the line.
And that fear, it really drove a massive migration toward ketamine because ketamine is the cool drug. It's the dissociative.
Right.
And the teaching, at least what I was taught in residency, was that it's hemodynamically favorable because it kicks up your catecholamines. It stimulates the sympathetic nervous system.
That is the classic teaching. Ketamine maintains hemodynamics. And in a healthy person, or say a trauma patient with an intact adrenal gland, it generally does. Ketamine inhibits the reuptake of norepinephrine.
Right.
It effectively floods the system with your own catecholamines.
So heart rate goes up, contractility goes up, blood pressure goes up.
It's a stimulant, essentially.
So if I have a septic patient who is hypotensive, why on earth would we think ketamine is dangerous? If they are soft, don't they need that catecholamine surge? It sounds like the perfect drug.
And this is where we get into the nuance that often gets missed in the textbooks, and it's really the crux of the hypothesis for this trial. Ketamine is a pharmacological Jekyll and Hyde.
Jekyll and Hyde, explain that.
Yes. Its indirect effect, the one we all rely on and love, is to boost catecholamines. But its direct effect on the heart muscle is actually negative inotropy. It is a myocardial depressant.
Wait, hold on. I've used ketamine for 10 years. You're telling me it lowers blood pressure. That goes against, well, everything I've seen. It's supposed to be the upper?
Directly, yes. If you take a strip of heart muscle in a petri dish and you put ketamine on it, it squeezes weaker, not stronger.
Wow.
It inhibits calcium transport. It depresses the myocardium.
So why don't we see that in practice? Why isn't every patient getting hypotensive?
Because it's usually masked.
Yeah.
In a healthy person, or even a moderately sick person, the massive release of norepinephrine from their adrenal glands completely overwhelms that direct depression. The upper effect wins.
Okay.
The sympathetic surge is just louder than the direct depression.
Okay, I follow you. But, and I assume there is a but coming, what if you are that septic patient we talked about? The one who has been fighting an infection for 3 days before they finally crashed?
They are running on fumes. They are what we call catecholamine depleted. Their adrenal glands have been squeezing out adrenaline and noradrenaline for days. They're dry.
So there's nothing left in the tank?
Nothing. So if you have no norepinephrine left to release, what happens when you push ketamine?
You don't get the surge.
You don't get the surge. And if you strip away that sympathetic surge, what is left?
Just the direct depression, the negative inotropy.
Precisely. You uncover the monster, you get the direct negative inotropy without the sympathetic safety net. So the safe drug might actually cause profound hypotension in the very patients you're trying to protect.
That is a terrifying concept. It basically means we might have been choosing the stable drug and accidentally tanking our sickest patients because we didn't understand that dual physiology.
That is the fear. And that is why this trial was so necessary. We needed to know if that theoretical catecholamine depletion crash was real or if it was just physiology fan fiction. We needed to move past the vibes and look at the data.
Which brings us to the mission of this deep dive. We are going to put aside the "I feel like this works better" and look strictly at the data from this NEJM trial. We want to know 2 things. Does switching to ketamine save lives by avoiding adrenal suppression?
Yeah.
And does it actually support blood pressure better than Etomidate?
That's the mission. We have a massive data set here, and the answers are, well, they're quite illuminating.
So let's get into section 2. What did they actually do? Give us the lay of the land on the trial design.
Okay, so this was a pragmatic, multi-center, randomized controlled trial. And I want to pause on that word pragmatic because it's important.
Yeah, we hear that a lot. What does it actually mean in this context? Is it just a buzzword?
It's not. It means it was designed to fit into the messy, chaotic reality of clinical practice. It wasn't happening in a sterile lab with perfect conditions. It was happening in real EDs and real ICUs with real clinicians making split-second decisions.
Okay, so real-world evidence. I like that.
Exactly. And the size of this thing is impressive. We aren't talking about 50 patients here and there.
No, not at all.
They included 2,365 critically ill adults. All of them were undergoing tracheal intubation in either the ED or the ICU. This makes it one of the largest airway trials ever conducted.
That's a huge number.
Right.
Were there any key exclusions we need to know about? Because sometimes you read a study and realize they excluded everyone you actually take care of. Like, oh, they excluded anyone with a fever or a lactate over 2.
Oh, right. Thankfully, no. They kept it broad, which is great for generalizability. The main thing to note, and this comes from the paper, is that this was for non-traumatic critically ill adults.
Okay, so no car crashes.
Exactly. If you have a massive trauma patient, a gunshot wound, a bad MVA, this specific data set might not apply perfectly. But for your medical ICU patients, your septic ED patients, your pneumonia patients who are tiring out, this is their cohort.
Okay, so we have roughly 2,300 patients. How did they split them up? What were the 2 arms?
It was a simple 1.1 randomization. Group 1 got ketamine. Group 2 got Etomidate.
Now, dosing. Dosing is always a fight. You hear people say, oh, the study failed because they underdosed the ketamine or they overdosed the Etomidate. Did the protocol handcuff the doctors? Were they forced into a specific dose?
No, and that fits the pragmatic design.
Yeah.
The trial protocol, which we have, allowed for clinician discretion. So the person at the bedside could adjust based on the patient's size and, how sick they looked.
But they gave them some guidance.
They did. They provided nomograms to guide the teams. And when you look at the data in the supplement of what was actually administered, it aligns very well with standard practice.
Okay, give me the numbers. I want to know if they used pain dose ketamine or real induction doses.
For ketamine, the median dose used was 1.6 milligrams per kilogram. The paper reports an interquartile range of 1.4 to 2.8.
Okay, so 1.5 to 2 millig a kilogram. That is a solid induction dose. That's not an analgesic dose. That's a put you to sleep for intubation dose.
Exactly. It was anesthetic dosing. And for Etomidate, the median dose was 0.28 milligrams per kilogram with an IQR of 0.24 to 0.31.
Again, right on the money for the standard 0.3 milligram dosing we all use.
Right in the pocket.
Okay, so we can't blame the dosing if we don't like the results. Now, I want to talk about how they actually randomize these patients, because whenever I see a trial this big in the ER, I get suspicious. In a crash situation, nobody is logging into a web portal to get a drug assignment while the patient is turning blue.
No, speed is life here. There's no time for that. So they went old school. They used opaque, sequentially numbered envelopes.
The envelope method, classic, simple and effective.
It works. The key here, and this is crucial for the study's validity, is that the assignment remained concealed until the patient was officially enrolled.
So you decide the patient needs a tube, you decide they are eligible, you commit, then you open the envelope.
Precisely. And this brings up a massive point of contention with this paper and something we have to talk about. This study was unblinded.
Correct. It was unblinded. The clinicians, the nurses, the RTs, everyone in the room knew what drug was being pushed.
They did.
I can hear the skeptics screaming already, unblinded, well, the whole thing is trash. If I know I'm giving ketamine, maybe I treat the patient differently. Maybe I'm more likely to start pressors because I expect them to be stable, or maybe I'm less aggressive with fluids. Doesn't that break the study?
It's a completely valid concern, and we need to address it honestly. But we also need to understand why they did it this way. There are two reasons. One is practical, and one is methodological.
Okay, lay it out for us.
Practically, it is extremely difficult to blind these two drugs.
Because they look different, right?
They look completely different. Ketamine looks like water. It's a clear fluid. Etomidate is a lipid emulsion. It looks milky, like propofol.
So to blind it, you'd need the pharmacy to mix up a fake, milky placebo for the ketamine group and a clear placebo for the Etomidate group, all in real time.
And in a crash intubation, waiting 15 minutes for pharmacy to mix a custom syringe is impossible. You need the drug in the room now. It's a logistical nightmare.
Okay, that makes sense.
Plus, even if you could mask the fluid, say, put tape over the syringe, ketamine has a tell.
The eye wiggle.
Nystagmus.
Yes, that rhythmic eye movement. Any seasoned clinician would know within 30 seconds which drug the patient got, regardless of what the syringe looked like. So blinding was likely impossible to maintain anyway.
But doesn't that still introduce bias? The fact that the clinicians knew.
It can, but this leads us perfectly into our first teach the fellow moment. We need to distinguish between two concepts, allocation concealment and blinding, because people use them interchangeably all the time, but they are very different things and they protect against different biases.
Okay, let's unpack this. This is important. What is the difference? Allocation concealment happens before the patient enters the trial. It protects the randomization sequence itself. It prevents selection bias. The opaque envelope does this.
Give me a concrete example of how that works.
Okay. Imagine you are an ER doctor. You have a patient in bed 4 who looks terrible, like about to die terrible, and you have a personal bias. Maybe you really believe Etomidate is bad for sick people. You want ketamine for this patient.
Okay, I'm biased. I want to save this person, and I think ketamine is the magic bullet for them.
If the trial didn't have allocation concealment, let's say the envelopes were see-through or there was just a list tacked to the wall, you could look at the next assignment, see it as Etomidate, and say, you know what? I'm not going to enroll this patient. You skip them. You wait for a ketamine assignment for your sick patient.
Ah, so that's selection bias. I'm gaming the system to put the sickest patients in the group I think is better, or the less sick patients in the group I think is worse.
Exactly. And that completely destroys the trial from the get-go because the groups are no longer equal. Allocation concealment, the opaque envelope, prevents that. You commit to enrolling the patient, then you open the envelope. You are stuck with the assignment.
So this trial had good allocation concealment.
It had perfect allocation concealment. The group started the race on an equal footing.
Okay, so the start of the race was fair. But what about the race itself? That's where blinding comes in.
Right. Blinding happens after the intervention. It prevents observer bias and performance bias. If the outcome was subjective, like did the patient look comfortable, knowing they got ketamine might change your perception.
Right, you'd be looking for things to confirm your belief.
Exactly. But here, the outcomes they chose are hard outcomes.
You mean death.
Right. Death is the ultimate hard outcome. You can't bias death. The patient is either alive or dead at day 28. Whether the doctor knew they got Etomidate or not doesn't change the fact of mortality.
It's hard to fake a death certificate.
It is. So unblinded trials are generally considered acceptable when the primary outcome is objective and hard, like mortality. The lack of blinding is a limitation, for sure, especially for the secondary outcomes. But for the primary question of does Etomidate kill people, it's not a fatal flaw.
That makes a lot of sense. It gives me more confidence in the results. Okay, so speaking of outcomes, let's list them out clearly. What were they measuring?
The primary outcome, as we said, was in-hospital death by day 28. Simple, binary, crucial.
The most important outcome. And the secondary outcome. This is where the hemodynamic stuff lives.
The key secondary outcome was cardiovascular collapse. But we need to be very, very specific about how they define this, because collapse can mean different things to different people.
Yeah, to me, collapse implies CPR is in progress.
Yeah.
But they had a broader, more systematic definition, right?
They did. According to the protocol, they defined cardiovascular collapse as any of these events occurring specifically in the window between induction agent administration and 2 minutes post-intubation.
That's the danger zone, the period of apnea and laryngoscopy.
It is. And to meet the criteria for collapse, you needed one of three things. Number one, a systolic blood pressure, or SBP, of less than 65 millimeters of mercury.
Wow, okay. That's pretty low. That's not just soft. That's hypoperfusion territory. If my patient hits 64 systolic, I am sweating.
Agreed. Number two, new or increased vasopressors. So starting a drip or bolusing pressors when they weren't on them before, or cranking up a drip that was already running.
Okay, so an intervention to support pressure.
Correct. And number three was cardiac arrest.
Okay, so SBP under 65, needing more pressors, or full-blown arrest, all happening in that critical induction window.
Precisely. That's the composite outcome they were looking for.
All right, we've set the stage. We've got the patients, we've got the drugs, we've got the definitions. Let's get to the part everyone is waiting for, the results. Section 4. Who lived and who died? What did they find?
Let's look at the primary outcome first. In-hospital death by day 28. In the ketamine group, there were 11,173 patients included in the final analysis. The number of deaths, according to the main paper, was 330. That is a mortality rate of 28.1%.
28.1%.
Okay.
That's about what you'd expect for a critically ill cohort needing intubation. And the Etomidate group?
In the Etomidate group, there were 11,186 patients. The number of deaths was 345. That is a mortality rate of 29.1%.
28.1% versus 29.1%. That sounds remarkably similar.
It is remarkably similar. The absolute difference is negative 0.8 percentage points. When they ran the statistics, the 95% confidence interval ranged from negative 4.5 to 2.9, and the p-value was 0.65.
So a confidence interval that widely crosses zero and a p-value that's not even close to significant. Statistically speaking, there is absolutely no difference.
None whatsoever. If you look at the Kaplan-Meier survival curves in the paper, figure 2, the two lines are practically hugging each other the entire way out to day 28. They are superimposed. You can't even tell them apart.
So what does this all mean for the old dogma? The fear of adrenal suppression that has haunted us for decades.
It means that in this large, pragmatic trial of critically ill adults, the theoretical adrenal suppression caused by a single dose of Etomidate did not translate into increased mortality.
That is huge. I mean, we have spent decades wringing our hands over 11 beta-hydroxylase, worrying that we were slowly killing our patients by suppressing their cortisol, and it turns out, at least for survival, it's a wash.
It appears so. The poison of Etomidate, as some used to call it, does not seem to be killing patients in this population. The boogeyman might not be real.
But wait, here is where it gets really interesting. Because if mortality is a wash, if it doesn't matter which drug you use for survival, then the tiebreaker has to be the immediate safety profile, right?
Of course.
How did the intubation actually go? Which one was smoother?
Exactly. If both drugs result in the same survival rate, you want the one that makes the procedure safer and less chaotic. The one that doesn't cause a crisis in the first 5 minutes.
And going back to my residency training, and I think everyone's training, ketamine is the stable drug. It supports blood pressure. So I assume ketamine won the secondary outcome, right? It must have had less collapse.
This is section 5,
Yeah.
and this is where the results essentially flip the script on common knowledge. This is the part of the paper that made everyone's jaw drop.
Okay, don't bury the lead. Let's talk about that secondary outcome, cardiovascular collapse.
Right. Remember, this is that composite of low pressure, needing pressors, or arrest. In the ketamine group, the group that got the stable drug, 22.1% of patients experienced cardiovascular collapse.
Okay, 22%, so about 1 in 5. And etomidate.
In the etomidate group, 17.0%.
Whoa. Wait, say that again? Ketamine was higher.
It was significantly higher. The absolute difference is 5.1 percentage points, with a 95% confidence interval of 1.9 to 8.3. That interval does not cross 0. This is a statistically significant finding.
So ketamine was associated with more cardiovascular collapse than etomidate? That is exactly the opposite of what I expected and what I was taught. You're telling me the hemodynamically stable drug caused more instability.
That is what the data from this trial shows. But we need to peel back the layers here. Cardiovascular collapse is a composite. We need to know what drove that number. Was it cardiac arrest? Were people coding on ketamine?
Yeah, that's the most important question. Did it stop hearts? Because if it did, that's a whole different story.
No, that's a key point. The rate of cardiac arrest, as reported in the supplementary appendix, was roughly 1% in both groups. There was no difference there at all. So it's not killing people on the spot.
Okay, so it's not stopping hearts. Was it the raw blood pressure number, the SBP less than 65? Was that more common with ketamine?
That was relatively similar to 6.4% in the ketamine group versus 5.5% in the etomidate group. A slight signal, maybe, but that small difference wasn't the main driver of the overall result.
So if it wasn't arrest and it wasn't the SBP threshold, what was it? What made the ketamine group collapse more often?
It was the vasopressors. The criterion of new or increased vasopressors occurred in 21.3% of the ketamine patients versus only 15.9% of the etomidate patients.
That is a big difference. That's the signal.
That's the entire signal. It tells us that the clinicians at the bedside were having to intervene to support the blood pressure significantly more often when they used ketamine.
This brings us to our second Teach the Fellow moment. Because when we hear 5.1% difference, it can sound small to a layperson. Oh, 5% difference, who cares? But in the world of clinical epidemiology, an absolute risk difference of 5% is substantial. It's not trivial.
It is massive. And the best way to conceptualize this for bedside practice is the number needed to harm, or NNH.
Okay, I always mess this up. Walk me through the math. How do we get that number? It sounds complicated.
It's actually the simplest calculation in the world. It is the inverse of the absolute risk difference. You just take 1 and divide it by the risk difference. In this case, the difference was 5.1%, which as a decimal is 0.051.
So 1 divided by 0.051. I'm doing that on my phone calculator right now.
Got it.
It's 19.6.
So let's round that up to 20 to make it easy. An NNH of 20.
So translate that for the listener driving to work right now. What does an NNH of 20 actually mean in my ICU next week?
It means that for every 20 patients you intubate with ketamine instead of etomidate, 1 additional patient will suffer cardiovascular collapse, specifically requiring new or increased vasopressors, who wouldn't have suffered it if you just used etomidate.
1 in 20. If you work in a busy ICU or a busy ED, you intubate 20 people pretty quickly. That means once a month, maybe even once a week, you might be causing a collapse event just by choosing the cool drug.
Exactly. It's not some rare 1 in 1,000 side effect. It's common. It's a 1 in 20 event.
Yeah.
And while it didn't translate to death by day 28 in this trial, anyone who works in critical care knows that hypotension and the need for pressors are not benign events.
Not at all. Hypotension kills kidneys. It stresses the heart. It causes secondary brain injury. It turns a controlled procedure into an absolute fire drill.
Exactly. It's a rocky start to a critical care course that you'd really rather avoid if you can.
So the hemodynamically stable reputation of ketamine, is it dead? Should we just stop saying that?
I think we have to say that in this population, the critically ill, the septic, the medically complex, it certainly does not hold up as superior. In fact, it appears inferior to etomidate in keeping the blood pressure stable without intervention. That theory we talked about at the beginning.
The Jekyll and Hyde thing.
Yes. The catecholamine depletion, revealing the negative inotropic effects. This data provides strong clinical support for that physiological theory. It seems to be what's happening.
Now I know what the listeners are thinking. The specialists are already poking holes. But surely it worked for the septic patients, or the ones with really high Apache scores. Maybe it was just the cardiac patients who did poorly with ketamine.
A classic and important question.
So Section 6 looks at the subgroups. Was there any specific group where ketamine actually won? Any pocket of patients where it was the better drug?
The short answer is no.
Not even the septic shock patients? The ones we were worried about adrenal suppression in with Etomidate?
That's the most interesting subgroup, right? You'd hypothesize that if Etomidate is bad because of adrenal suppression, it would be worse than septic shock.
And ketamine, with its catecholamine surge, should be best in septic shock.
That's the hypothesis. But the investigators looked at sepsis versus no sepsis. They looked at high severity of illness. So high Apache 2 scores versus low severity. They produced forest plots for all of this, which you can see in figures S4 to S6 in the supplementary appendix.
And what did the plots show?
No significant interactions. The results were consistent across the board. The mortality was the same in sepsis and no sepsis. The cardiovascular collapse was worse with ketamine in sepsis and no sepsis.
So it didn't matter.
It did not. Now, I have to add a caution here, because this is a common trap. Sometimes you look at a forest plot and your eye wants to see a pattern. You might see a dot drifting a little to the left or a little to the right.
The ocular traumatic test of statistics. It looks like it's moving. You just stare at it until it tells you what you want to hear.
Right. But we have to trust the math. We have to look at the statistical tests for interaction, the p-value for interaction. The paper is clear. Those tests were not significant. That means we cannot claim that ketamine was better for sepsis or worse for sepsis. The main finding stands for everyone.
So no hiding place for the ketamine enthusiasts in the subgroups.
Not in this data. The effect seems to be consistent across the different types of critically ill patients they enrolled.
Okay, usually at this point in our deep dive, we like to see what the editorialists had to say, some wise elder of the tribe, giving their 2 cents on the study, putting it into context.
Right, the perspective piece. In this case, checking our source material, the provided notebook did not include the editorial text.
Okay, so we can't report on it. The editorial perspective is not recorded in the provided materials.
Correct.
So we are flying solo on the interpretation. We won't speculate on what they might have said. We will stick to the cold, hard numbers we just reviewed.
Which, frankly, speak for themselves quite clearly. There isn't much ambiguity here.
They really do. So let's pivot to the most important part. Section 8, the What Do We Do Monday playbook. Because this is where the rubber meets the road. You're on shift Monday morning. A patient comes in, septic, looking terrible. They need a tube. How does this paper change what happens in that room?
Let's break it down by role, because this affects everyone in the room. The physician, the nurse, the RT, the pharmacist.
Perfect. Let's start with the physician or the APP, the one holding the laryngoscope and ordering the drugs. What's their new playbook?
If you are the provider making the choice, I think this trial simplifies your life immensely. You no longer need to agonize over adrenal suppression with Etomidate. That fear, which has been a major cognitive burden for years, should be put to rest.
So the Etomidate kills people later argument is off the table based on this?
Based on this data, yes. And knowing that, you are left with the immediate hemodynamic profile. Which drug is safer in the moment? The data clearly shows Etomidate is more stable. Ketamine carries a 1 in 20 risk of causing a collapse event requiring pressors.
So if I want a smooth intubation with less chaos, fewer alarms, and less scrambling in the first 2 minutes, Etomidate looks like the winner.
It does. It effectively reclaims its title as the default induction agent for the undifferentiated critically ill patient. If you choose to use ketamine, you aren't doing something wrong, per se. Mortality was the same. But you need to go in with your eyes wide open, meaning you are choosing a rockier path to get to the same destination. You are choosing a path with a statistically higher chance of alarms and interventions. You have to be ready for that hypotension.
Okay, that's crystal clear for the provider. What about for the nurses and the respiratory therapists, the people standing right next to the bed monitoring the patient?
For the team, this paper emphasizes the danger of that induction to 2-minute window. This is the danger zone.
We always focus on the oxygen saturation, watching the SAT probe like a hawk. But this trial reminds us the blood pressure cuff is the other cliff you can fall off of.
Exactly. And the takeaway is about anticipation. If the doctor orders ketamine, the team needs to be hypervigilant about the blood pressure. Do not assume that because it's ketamine, the BP is safe. In fact, you should anticipate the opposite.
So practically speaking, if I hear ketamine 150 milligram, I should probably have the push-dose pressors in my hand and ready to go.
Or have the norepinephrine hanging on the pump and primed to the patient.
The study showed a significant increase in the need for new vasopressors. You don't want to be spiking a bag of Levo while the pressure is 60. You want it ready before the drug even goes in.
That is a great, tangible takeaway for the team. Ketamine ordered, pressors ready.
I would argue induction-ordered pressors ready is best practice regardless of the agent. But this trial reinforces that ketamine is absolutely not a magic shield against hypotension. Don't be complacent.
Love it. And finally, for our pharmacy colleagues, what's the takeaway for them? I think it speaks to standardization and readiness. If your institution's RSI kits or protocols rely heavily on ketamine because of the old dogma, it might be time to revisit that and ensure Etomidate is just as accessible.
And maybe more importantly,
ensuring that vasopressors are not locked away in a Pyxis down the hall during an intubation. They need to be at the bedside, immediately available. The data on collapse happening within 2 minutes proves you don't have time to run to the medication room and type in a password.
Absolutely. The speed of onset of these collapse events is scary fast. If you have to leave the room to get the levo fed, the patient has already hypoperfused their kidneys and their brain for too long.
It is an immediate event. It requires an immediate response. Pharmacy can champion that readiness.
This is all incredibly practical. Okay, so let's wrap this up with our closing synthesis. Section 9. Give me the 3 things the listener needs to tattoo on their brain from this deep dive.
Take-home point number 1, mortality. In this large randomized trial, there was no difference in 28-day survival between ketamine and Etomidate. The adrenal suppression theory of Etomidate mortality is effectively debunked in this general critically ill population.
So we can stop worrying about that. Point number 2.
Safety. Ketamine was associated with a significantly higher rate of cardiovascular collapse compared to Etomidate. Specifically, it required more rescue with vasopressors in the immediate peri-intubation period.
So the hemodynamically stable reputation of ketamine is challenged.
Challenged, if not overturned, in this specific context.
And point number 3, what's the last big idea?
The standard of care. For the routine crashing patient, Etomidate is supported by high-quality evidence as a stable, safe choice. Ketamine remains a viable option, but it's not a free lunch. It carries a higher burden of hemodynamic intervention, and your team must be prepared for that. It is not the set-it-and-forget-it stable drug we perhaps hoped it was.
There you have it. The king is dead. Long live the king. Etomidate is back on the throne.
Or perhaps never really left. It was just waiting for the evidence to catch up.
Fair enough. All right, that's a wrap on the RSI trial, a landmark paper. If you found this helpful, share with a colleague, subscribe so you don't miss next week's study.